you all see the slide?
Yes.
All right. Diagnostic histopathology. Okay. About this topic. Okay. Basically, this is what we need to learn from this topic. Introductions. Okay. Then we need to cover what are the component in the histopathology, cytopathology, ancillary technique that we have, and last one, frozen sections. Okay. Okay, for the introductions, okay, when we say diagnostic histopathology, basically is actually is a process to detect disease based on gross and microscopic finding with additional informations or investigations on the ancillary technique like chemical, immunologic, molecular examinations of the organ, tissue, any specimen that you provide to us, or autopsy, the whole body. And then or others will look on the analysis of body fluids such as blood and urine. Yeah, and finally we can get the correct diagnosis. That's the definitions. So for in the anatomic pathology, we have two fields, two components. Okay, histopathology and cytopathology. So we look one by one. Okay, histopathology basically we study disease of the tissue. Okay, when we examine the entire tissue, this meaning in the histopathology, we examine the cells. Just now when you learn in the neoplasia, they have two components of the tumors, right? They have the cells and stroma. So in histopathology, we need to study both cells and also surrounding stroma when we want to make a diagnosis. Okay, for in histopathology, we have two main important work. What we do is we examine the gross specimen and microscopic analysis. Okay, for a gross examination is about we see the gross, we look at the size of the lesions, tumors, the shape of the tumors, and then we need to look any abnormalities like ulcerations, nodularity, and from there we need at least have an idea. Is it neoplastic or neoplastic lesions? When there is neoplastic, we need to further divide it. Is it benign tumor or malignant tumor on grossly? And then what we do is we need to select the interest areas or the lesional areas for microscopic analysis. Okay, these examples, okay. This again the mastectomy specimen with the axillarities. This is the anterior view. This is the posterior view. Normally we cut serially the specimen from the posterior because it's more easy. So when we get the specimen like this, we need to serially cut the specimen. Why we did this? Because we want to see the lesion clearly. And then also we want to select which area we want to take and process for analysis, microscopic analysis later, right? Okay, this one examples of the hepatectomy specimen. This is a liver tissue. Then this is the adjacent. Here is a tumor. Okay, when we get this specimen, okay, as I mentioned to you, we need to analyze first on gross examinations. Gross examination, we examine grossly. We need to know first, is it neoplastic or non-neoplastic? So we know this is a mass or is it non-neoplastic? Is it neoplastic? When we see neoplastic, we need to further divide. Is benign or malignant? So we need to look all the characteristic or evidence points towards benign or malignant tumor. So we look at the age of the lesions here. We can see the age is not really well circumscribed. Okay, and then the cut sections here of the tumor, is it heterogeneous or homogeneous? Homogeneous is more likely a benign tumor. Heterogeneous, why? Because they have the necrosis, hemorrhage is more in the malignant conditions. Okay, this one pictures of the kidney. Okay, this is actually a nephrectomy specimen. We cut into two. So we can see here this. This is how the typical renal cell carcinoma looks like. You can see grossly well circumscribed tumor actually, but we have the golden yellow colored because of the glycogen rich. And here we can see hemorrhage here. Okay, it's a renal cell carcinoma. Is again, after we get the specimen, okay, first we do is a gross examination. When we do finish the gross examinations, then we select the interest area. So we want to transform into a slide like this, because this is the slide we want to do the microscopic analysis. Okay, they have a long process from here into slide. Okay, so I just want to briefly tell you what are the process involved in that in slide formations. Okay, before, okay, when we get specimen from you all, okay, when we do the surgery or do the autopsy, okay, when we get the specimen, when you do the surgery, you need to immediately put the all specimen into formalin, because they are the first step. Physicians, it's a very important step. Okay, I will tell you further what are the importance of the physician. Okay, this is the first step. Okay, so for physicians, it's depending on the size of the specimen. Okay, for the big specimen, normally it takes 1 day to fix. Okay, so meaning when we get your specimen, okay, so we need to fix for 1 day. So this is day one story. Okay, day one we need to fix the specimen first. Okay, and then the second day what we do is grossing. Grossing meaning we need to do the gross examinations and selections of the interest areas. That's the grossing definitions in the second day. Okay, after we take the sections, okay, what we do is the next process is processing. So we all the tissue selection here. Okay, and then the next step is processing process. Okay, it took overnight process around 10 to 12 hours. So this is the third day's third day's process. Okay, third days for processing all the selected samples in the machines. So these are the process that occur in that machine. Dehydration, clearing, impregnation, all happen in the machines. Okay, so it's the third day, and then the next day, the fourth day, what happened here? So you know, during grossing, okay, we cut the tissue very thin, around 3 to 4 mm. Okay, with these thin sections, it's quite difficult for us to further sections to make it into slide. So here comes the embedding process, meaning we need to put something, some substance. Here we use the paraffin to make it the tissue more bigger and more harder, so that when we cut the tissue is easier. Okay, so and then in the fourth day, what we do is embedding paraffin block. We put paraffin in the tissue sections, and then we can cut the tissue, and then after that we can stain the slide. The first stain we do is H&E stain. Okay, so and last one we can make a diagnosis. Okay, normally the process is took around 4 or 5 days. That's why our turnaround time for urgent biopsy without any staining, any further immunohistochemistry is 5 working days, because this includes all the process, right? So this is similar like I mentioned to you. So you can see this is specimens that we get, and then we need to put immediately into the formalin. After that, what we do here is a grossing examinations. We examine the specimen, we take sections, and then this is a processing machine. Okay, this is the embedding, meaning we put the tissue just now into a mold. This one you call as mold, and then we pour the paraffin. So make it like this. So here is easy for our staff to slice or cut the sections into thinner sections. Okay, and then it puts on the glass slide here, and then after that stain. Then we get the slide, we can make the histologic analysis. Right. Okay, on examination, what we saw just now, we get the mastectomy specimen. So what we saw on histology, okay, this is all the tumor tissue. Okay, this tumor tissue occur in the lobules. Okay, it's a lobules of tumor with still we can see the myoepithelial in the surrounding tumor tissue. So this is in situ, meaning this tumor is not invaded into the stroma yet. So we call as a lobular carcinoma in situ. Whereas in these pictures, we can see these tumors are already invading into the adjacent structures because they make the arrangement of the cells in the single lining here. Single lining, or other name we call as a India line, okay, but there is no tubule formation here because in this is an invasive lobular carcinoma. Normally the cell will arrange in the one layer only like this, okay. And the individual tumor cells, they have evidence of aneuplosia because they're malignant. Okay, physations, a little bit about physations. Okay, physation is actually is a process by which the constituents of the cells and tissue are fixed, either physical or chemical, so that this tissue can withstand the subsequent treatment with various reagents with minimum loss of architecture. Okay, so the physation should if we want to fix any tissue, okay, the volume of physations must be 15 to 20 times more than the volume of the specimen. So meaning you need to put a lot of the formalin for better physations of the each specimen. Okay. For aim of physations, it should prevent autolysis and purification of the cells, so we can maintain the architecture of the cell for easy for us to make analysis under microscope. And the physations should penetrate evenly and rapidly and should harden the tissue so that easy for us when we cut the tissue during the gross examinations. Increase the optical density is not cause shrinkage or swelling of the cells sometimes, because when we look on histology, we need to analyze all the individual tumor cells. If the formalin or physations cause the tumor cells become very enlarged, it's quite difficult for us to see the morphology. Okay, and also the physician must not react with the receptor site, and thus must not interfere with the staining procedures, and it must be cheap and easily available. Okay, they have two type of physations: physical physation, for example, heat and freezing, and chemical physation, formalin. They have a lot of more type of chemical physation normally, but the most common one we use formalin because this one is the most established physations. Okay, for physical freezing we use during frozen sections. Okay, no physician will penetrate a piece of tissue thicker than 1 centimeter. That's why when we get a big specimen like mastectomy specimen, okay, on the same day we need to slice the specimen into 1 centimeter so that the physician can penetrate each of the tissue. Okay, so it take 4 mm thick to fix in 8 hours. That's why we left overnight 1 day to fix the big specimens. Then we can gross. Okay, what are the advantages of the formalin? It's cheap. It have good penetration into the tissue. It causes very little shrinkage of the individual cells. It can preserve the RBC and fatty tissue. It can use the spatial stain. Okay, meaning that after we fix with formalin, this tissue can be further staining with immunohistochemistry, spatial stain, and other staining also. Okay, can preserve the color of the tissue and good hardening of the tissue. Formalin also they have the disadvantages. Okay, this is the few disadvantages of formalin. For the longer time when we preserve or fix the tissue in the formalin, okay, it will cause formic acid will be formed, which affects sustainability of tissue with different stains. So we need to change every 3 to 6 months. But for our protocol, we kept the specimen 6 months after the result validated. Okay, after that we can dispose the specimen. All right. Okay. When formalin formations solution is stored for a longer time, it can cause a white precipitate, so that we cannot store the formalin in the longer periods of time. Okay. And then formalin also cannot preserve the glycogen. That's why when we get adipose tissue, right? For example, lipoma. Okay, lipoma is an adipocytic tumor. Okay, for adipose tissue, they contain a lot of glycogens, right? So this glycogen actually dissolve during the processing because of the formalin just now. So what we saw in histology, they just left the empty spaces. Okay, meaning that they cannot preserve the glycogen. We cannot see glycogens when we fix using the formalin on histology. When we want to saw the defects tissue, we need to use the fresh tissue. Okay, and the very dangerous one is a carcinogenic. In study, they showed they associated with certain type of tumors when we expose too much into formalins. Okay, this is the pictures to differentiate. This is without physician. This is with physicians. Okay, we can see actually this is a similar tissue. This is called small bowel tissue because we can see this is a villi here. Okay, when specimen is fixed with any physician, in our case we use formalin, we can see clearly the outline of the cells, the individual cells here. Like this, a very nice villi, and we can assess all the individual cells. In the stroma, lamina propria here, they have a inflammatory cells. Okay, whereas in the non-fixation tissue, it's very difficult to see the morphology of the cell because the cell already autolyzed. Okay, you cannot see clearly the goblet cells. You hardly see is it necrosis or not. So it's very difficult for us to make any decisions, right? Then after that we stain. This is the first staining after when we get the slide. Okay, this is the first staining we did is the hematoxylin eosin stain or H&E stain. Okay, for H&E stain only have two colors. Okay, blue, purple, and pink. They have two colors only. So for blue, purple is stain the nucleus, whereas the pink is stain the cytoplasm and the extracellular matrix. So when we look on histology, they have only two color only. Okay, and H&E also give rapid, comprehensive, and informative scope of the scene. So from here, we need to make a histology analysis, and then in the straightforward cases, we can give a correct diagnosis. But in other cases, we need to proceed with other ancillary technique I show you after this. Okay, this is how the H&E stains looks like. Okay, this is a colon. Okay, section for colonic tissue. This is colonic glands. Okay, this is lymphoids aggregates forming a germinal center here. Okay, on high magnification, you can see only two color. The blue stain the nucleus, and the pink stain the cytoplasm. And we can see clearly in the stroma, they have many inflammatory cells. Okay, they have here plasma cells, this one plasma cell, lymphocyte. In the crypts here, we can see neutrophil aggregates. This one we call as a crypt abscesses. Right? Okay, again in the histologic examinations, this is sections from the lymph nodes. Okay, this is a tumor cells. It is red stumble cells. You can see binucleated cells with a very prominent eosinophilic nucleoli. Okay, this is actually Hodgkin cells. This is a Hodgkin cell with the surrounding reactive inflammatory cell. You can see this is lymphocyte. Okay, this is again lymphocyte. And this one, okay, this is sections from the breast tissue. Yeah. Okay, you can see here, this is a duct and acina of the breast. Okay, when we look closer, actually, this duct and acina is lined by double layered epithelium. In normal breast duct and acini, the lining is double layered. The epithelial in the luminal areas, and the outer layer is a myoepithelium. Myoepithelium is more flattened like this, right? This is all myoepithelium. So when we see this double layer epithelium, we can say it's a benign breast acini or breast duct. Okay, next cytopathology. Okay, for cytopathology, okay, we only study the individual cells without the adjacent stroma. So we need to analyze the cells only. All right. So before we move further, we need to know the component of the cells. Okay. So the cell consists of nucleus and surrounded by the cytoplasm. Okay. The cytoplasm, they have many organelles, cytosol. This one I think you have learned in our biology class previous years, right? Okay, what are the components in the cytopathology? They have three components. Fine needle aspiration cytology. Okay, and they have body fluids, includes pleural effusions, urine, peritoneal, and pap smear. This is a gynecology smear. Okay, fine needle aspiration cytology is simple, quick, inexpensive method that used to sample superficial masses like those found in the neck and usually perform in the outpatient clinic. Okay, normally for FNAs, the mass must be at least 1 centimeter and more. If less than that, it's very difficult because our FNAs is a blind procedures. So we need to find the masses is clinically palpable, at least 1 centimeter. Right? Is less than that, we need guidance from the ultrasound guide during the FNAs. Okay, it causes minimal trauma to the patients and carry actually no risk of complications. And actually we use a very thin needles inserted into the masses, and then we smith on the glass slide. This is how we did the FNAs. Okay, first one, first step is we need to examine the patients and find the lump. Okay, the lump must be palpable. And then what we use is this is the shrink connect to the, usually we use the blue needle, very small needle, and connect to the, this is the handles to hold the holder to hold the shrink. Okay, because it's more stable when we aspirate the samples. And then after that, we need to fix the lump between two fingers, and in the middle of the two finger, we aspirate the lesions. Okay, and then after that, we put on the slide and smear. After smear, we stain. Okay, for FNA, we have two types of stain. Pap stain. This is a pap stain. This is a GIMSA stains, okay, MGG stain. All right. So for PET stain, is more useful to look at the nuclear features. You can see clearly the nuclear features. Okay, just now we aspirate the thyroid nodules. So you can see this is all the thyroid epithelial cells. Okay, is it abnormal or normal? Actually, it's abnormal thyroid epithelial. Okay, one abnormal. Okay, we need to analyze the individual's thyroid epithelial cells. Okay, by looking at the entire cells is pleomorphic, meaning they have variation in the size and shape. And then the nuclear features of the thyroid is vesicular, meaning you can see clearing of the nuclear features. And here you can see grooving inside the nucleus. This one we call as a nuclear grooving. This one again, the nuclear grooving, and this is a nucleoli. But here in this slide, I can't see any inclusions. Okay, pseudo intranuclear inclusion. Actually, this is a case of papillary thyroid carcinoma. Okay, they have the nuclear features of PTC. Okay, this is MGG stain. You can see for MGG, we want to look clearly the cytoplasm. Okay, for example, in lymphoma, we can see very bluish dark color cytoplasm, okay, in the lymphoma. So MGG more to cytoplasm, pap smear, pap stain more to the nuclear features. In MGG here, quite difficult for us to examine or analyze the individual nuclear features. That's why we need these two stain for diagnosis. Again, this one, this is from the breast aspirate. Okay, this is how the normal breast ductal epithelial cell looks like. Why I say it's normal? Because this is a this is a ductal epithelial cells. This one, the small like this, the small cell is a myoepithelial cells. When we see this dual population, myoepithelials and epithelial cells is benign sheets of ductal epithelial breast cells. Okay. So this is a PET stain. Actually, this is a apocrine cells. You know, in the breast disease, for example, in the case of fibrocystic changes, you can see the duct become cystically dilated and lined by the apocrine metaplasia. So this is how the apocrine cell looks like. This is a nucleus. They have the abundance granular cytoplasm. You can see the cytoplasm, they have something inside the cytoplasm. It's a granules. Okay? It's abundant and granules. So for body fluids, okay, it's very useful for diagnosis of malignant tumor, especially metastatic tumor. Okay, includes the inflammatory conditions like septic effusions, chronic inflammations, for example, in tuberculosis. So we can examine from any cavities from the abdominal, pleural, pericardial, synovial, and CSF. So this is pleural effusions. Okay, actually this one, this patient have a breast carcinoma already matched to the lung. They have also pleural, malignant pleural effusions. Okay, you can see this one light ball, right? It's very big groups here, big sheets. Sometimes we describe as a ball of neoplastic or malignant cells. These are the malignant cells. Okay. So again, we're on the PET stains here. These are clearly malignant cells. Why? Because they have all the anaplasia changes. You can see the cells is pleomorphic. They have the vesicular or hyperchromatic chromatin. The chromatin patterns is clump like this. They have a prominent nucleoli. Okay, so this malignant cells. Okay, PET smear is a screening test for cervical cancer and pre-malignant cervical lesions. Okay, actually, for cytology is a screening procedures. Okay, so for PET smear, okay, this is for PET smear, we have our standards criteria how to report the cervical cytology using the Bethesda system. Okay, basically in PET smear we have two techniques, conventional and liquid based. Conventional meaning the PET smear will stain by the staff in the ONG labs, okay, or in ONG clinic. Okay, meaning that after the doctors take the samples and the staff will will smear immediately. That conventional. For liquid base, when the doctor get the sample, actually the brush, they will insert it into the bottle containing a special liquid and then send to our lab. So we will make it into slide. So that one using the liquid base because they have a very specific medium. Okay, but the advantageous when we do liquid based technique because we can proceed with the HPV testing using the PCR test. Okay. All right, this is the books that we use for reporting cervical cytology, Bethesda system. Okay, this is technique how the doctors take the sample for pap smear. Okay, actually for cytology, each of the organ we have their own criteria system how to report. For example, in the thyroid, they have their own criteria how to report. Okay, for breast also they have their own criteria, own system on reporting. So we need to follow the standards criteria. Okay, this is how we classify for reporting in the cervical cytology. So we look at the either epithelial abnormalities or glandular abnormalities, okay, or we can see other infections like Trichomonas vaginalis, we can see Candida, we can see Deactinomyces or herpes. This one must be reported accordingly. Okay, these examples of pap smear. Okay, basically pap smear, you know, we look at the squamous cell because when the doctors take the samples, it must be in the transformation zone. So meaning this must include the squamous cells and endocervical cells. So now here we can see the squamous cells. Okay, we can't see any endocervical cell here, but for the squamous cells, okay, we need to know the morphology of the ectocervix because they have the basal layers, they have the superficial layers. Here, this one is all the superficial layer because we can see very small dark nuclei with the abundant cytoplasm. Okay, once it become malignant, what happened? Okay, so now we can see the nucleus become larger than cytoplasm. So we call as a high nuclear to cytoplasmic ratio. This is the nucleus is very large, the cytoplasm is scanty, and then the nucleus is look variation in size, pleomorphic. All right, this shape is round, this one quite oval in shapes. And then we can see here hyperchromatic here, this one nucleoli. Actually, this is a squamous cell carcinoma, similar to this. Okay, so you can compare here. This is a normal squamous cell with very small nucleus. This one, the nucleus is very big, hyperchromatic, and scant cytoplasm. Right. The background is a inflammatory cells, neutrophils. You can see mainly neutrophil because of the tumor necrosis. Okay, this is the ancillary technique. Okay, they have list of ancillary technique that we have when we have difficulty to diagnose only on the H&E sections. Okay, we have histochemical staining, immunohistochemistry, immunofluorescence, EM, molecular studies, flow cytometry, and cytogenetic study. Okay, for histochemical, but in our lab, okay, the available technique is histochemical stains, immunohistochemistry. We didn't do RF here. EM we have in the COM, but not for diagnostic, but it's very rare for diagnostic usage. For molecular study, we have for HPV testing by using the PCR. Flow cytometry is still not available yet. Cytogenetic, we are in developing for cytogenetic study in our lab. Okay. For histochemical stain, okay, actually it consists of the chemical reaction because the name is histochemical, so it's mainly involved the chemical reactions that demonstrate the cellular or tissue elements of interest followed by the chemical reaction to stain the background. Okay, we use histochemical stain to selectively stain cells and cellular component to characterize tissue. For example, we want to highlight the muscle fiber, we want to highlight the connective tissue, we have the spatial stain. Okay, okay. The second one, we want to identify non-cellular material like amyloid, we have the another stain. The third one, we want to identify from the infectious agent like tuberculosis, we have the other stain to see the organism. Okay, these examples of the stain and the usage of the staining. Okay, for example, this is a past periodic acid shift stain used for to look the basement membranes. Okay, highline materials. Okay, different silver or jones we use also for basement membranes details. Normally we use in the renal biopsy specimen. Okay, conglomerates. This one we want to highlight clearly the amyloids. Okay, and this one zilnicin. Okay, zilnicin stains is we want to see acid fast bacilli. Okay, on histology, okay, this is the H&E slide, what we saw here. I think you can recognize because before this, you have lectures with Dr. Hassana regarding granulomatous inflammation. This is a granuloma. Okay, granuloma is aggregates of the epithelial macrophages here. This is all the epithelial macrophages. surrounded by the lymphocyte here with scattered plasma cell. This one against the activated macrophages. We can see sometimes we say activated macrophages is the shape of the macrophage is elongated, slipper shapes. Okay. And then we can see here, this is a multinucleated giant cells. It's forming like horseshoe shapes we call as a Langhans type giant cells. Normally here when we see this type of giant cell, we can see necrosis is most likely a tuberculosis. So we need to proceed with a xylene sustain to confirm or to look for any acid fast bacilli. So this is the red color here, highlight the acid fast bacilli. There's a lot of numerous acid fast bacilli. Actually, when we see acid fast bacilli on xylene sustain, even one bacilli here, actually it's not represent one. Okay, it represent many numerous bacilli. Okay, that's why even we see one, we need to report. It's very significant. Unlike in this case, is very infectious. Okay, next, immunohistochemistry. Okay, I see by the name immunohistochemistry. So it's composed of the antigen-antibody complex. Okay, so it demonstrating the presence and location of the protein, meaning in IC actually we stain the protein. We look at the protein. This protein is called as an antigen. Okay. So we use either monoclonal or polyclonal depending in each of the antibodies on the specific antigen. Okay, so this is to identify, to confirm any tumors, because most of the tumor we can't make a diagnosis based on H&E alone. So we need further staining. Okay. This is sections from the lung, okay, because you can see this is a normal alveolar tissue here. So here malignant cells infiltrations. So you can see here the malignant cells is forming the glandular structures. You can see lumen spaces inside lining by the malignant cells. When you look on higher magnifications, again, the malignant cells is forming a glandular structures here, and the individual tumor cells here all shows the anaplasia features and anaplasia morphology. Okay, when we get a case like this, okay, when the specimen label as lung tissue, and then we saw lung tissue adjacent to the tumor, and the tumor is forming glandular structure like this, we can straightly say it's adenocarcinoma without any staining. Okay, because it's very straightforward cases. Okay, how about other case? It's also labeled as a lung tissue, but what we saw in the histology. Okay, this is tumor cells. Sorry. Okay, this is a tumor cells is forming in sheets. Okay, forming in sheets. Then it is very vague glandular structures, quite hard to tell. And this is the tumor cells individual in clusters. It doesn't forming any structures. It doesn't shows any squamous differentiation. We can't see any keratin pearl individual keratinization. We can't see here. So the most we can say is polydifferentiated carcinoma. But in lung carcinoma, you know, the broad category is non-small cell carcinoma and small cell carcinoma. And for non-small cell carcinoma, they have adenocarcinoma, they have squamous cell carcinoma, they have large cell carcinoma. But each of the tumor, they have their own chemotherapy, they had their own chemotherapy. So the treatment is different. So we need to really establish what are the type of the carcinoma. So in case like this, we need to proceed with a further immunohistochemistry to find the origin of these tumor cells. So by doing, first, normally we start with the CK7 and CK20 pattern, okay? Because from here we can narrow it down the tumor in origin is useful in metastatic disease when we get a specimen, for example, you send to us a cervical lymph nodes biopsy, okay? When we see a metastatic carcinoma, we doesn't know it's from where, okay? So the first step what we did is CK7 and CK20. Okay, when CK7 positive, CK20 negative. The differentials include lung, thyroid. If patient is female, it can be breast, it can be female genital tract. Okay, when it's reverse, CK20 positive, CK7 negative, it could be colorectals, it could be bladder, it could be salivary glands. So they have the list of the tumor. So from there, we can further narrow down. So each of the tumor, for example, colorectal, CK20 positive, CK7 negative, we have the further staining to confirm the colorectal. So we have CDX2, normally positive in colorectal cancer. So we see based on the case, okay? So our case here, we did CK7, so it's positive. And then proceed with the TTF1. TTF1 is a marker for lung and also thyroids. Okay, so but for this case, they have lung mass, they have no thyroid mass, so we can safely say is adenocarcinoma arise from the lung. All right. If not, we need to further evaluate its understanding to confirm it's not from the thyroids. For thyroid, we have another stain, thyroglobulin. So these are examples, all right? So for example, breast cancer, we can do ER, PR, GCD, FP15, mammoglobin. This one all related to the primary breast cancer. Lung, CK7, okay? If a neuroendocrine tumor, so you need to do the neuroendocrine marker such as chromogranin, synapto, NSE. This one germ cell tumor, they have many other staining for germ cells, right? Hepatocellular carcinoma, HEPA1, colorectal, CDX2, okay? All right. Next, immunofluorescence. Okay, immunofluorescence actually is also uses the specific antibodies which have been chemically conjugated to fluorescent dye. So for immunofluorescence, we need to use a spatial microscope because they have the fluorescent microscope. The normal microscope cannot. The light microscopy, we can't see the RF specimens. Okay, so in the RF technique or immunofluorescent technique is allowed for the visualizations of the present as well as the distributions of the target molecule in the sample. For example, in the case of the IgA nephropathy, this one from the renal biopsy, you can see this glomerulus. This is a tubules. Okay, on the H&E section, we can't see any deposit here. If we suspect it's IgA nephropathy, we can proceed with the immunofluorescence for IgA antibodies. Okay, here is a positive. Okay, this is IgD if I'm not mistaken. Okay, we have a few type of antibodies, IgA, IgD, IgM. Okay, so but then this must be visualized under the immunofluorescence microscope. Right, EM. EM actually use the beam of accelerated electrons as a source of the illuminations. Okay, for EM is a valuable standard tool in the research study and teaching. The usage in the diagnostic is very limited, it's mainly in the renal biopsy. For example, in the case of minimal change, because minimal change disease, for the renal biopsy, we can't see anything. We can see normal, this is normal capillaries, normal mesangial tissue, this is a glomerulus, right? This is a Bowman capsule. We can't see any deposit, any proliferations of the mesangial cells. It's look totally normal. When we look on EM, okay, you can see the fusions of the food processes. That the main finding that can only be seen on EM, okay, not on the light microscopy. But in case like this, we need to proceed with the EM studies. Okay, molecular study. For molecular study, dominant oncogenes and tumor suppression genes abnormalities are crucial event in human cancer. So meaning that we have a few techniques in the molecular study. Okay, so this is the list of the technique. Okay, but in our lab we have the PCR machine, cloning sequencing we doesn't have here. So by our PCR, we specifically tested for HPV testing only. But for others, we still developing. Okay, for the because we have the machines. Okay, for molecular, it used for diagnosis of malignant nucleism. In case of lymphoma, sometimes it's quite difficult. We want to say, is it polyclonal? Because polyclonal is benign, monoclonal is a malignant. Even though we already did the immunohistochemistry, sometimes it's difficult to give the lineage or make it, is it monoclonal or polyclonal? We need to proceed with a molecular study for confirmation. And for prognosis, pseudomyeloneoplasm, Burkitt lymphoma, we need to do CIMIC. Okay, for breast carcinoma, HER2. For HER2, okay, we can do either fish, but for ours we outsource to Pantai using the fish. In the other center, they use the in situ, okay. Bukan in situ, sorry, D-dish. All right, D-dish HER2. But for our, we use the fish. But both technique is established, okay. This can be done to assess the amplifications of the HER2. Okay, for the third usage is for detections of minimal residual disease in case of acute leukemia. And last one, diagnosis of hereditary predisposing to cancer. We want to see any mutations for any genetic events. BRCA1, BRCA2 can use a PCR. Okay, this is flow cytometry. Okay, flow cytometry basically a technique used to detect and measure physical and chemical characteristic of population of cells or particles. Is useful in differentiating the B and tumor, T and B abnormal lymphocyte. So meaning that we want to subtype the lymphoma or leukemia into B and T, and you know the B and T also they have many subtype behind and below that. So we need to do a complete flow cytometry so that we can give the final diagnosis of lymphoma and leukemia. Okay, cytogenetic study, the study of genetic phenomena through the cytological analysis of chromosome under the light of electron microscope. Okay, cytogenetic analysis can provide a presence of malignant clones. Second, can determine the cell lineage in the disease process, can clarify and confirm a diagnosis, can provide the prognostic predictive values, monitor the response to the treatment and classifications of the neoplasm in the very difficult cases. Okay. Okay, last one about frozen sections. Okay, frozen sections is a laboratory procedures to perform rapid microscopic analysis of specimen. This is definitions. Okay, other name for frozen sections is a cryosection. Cryosections is the machine that we use to freeze the specimen and cut the specimen. Okay, this is how the cryostat machines looks like. Okay. So this is how we do the physicians. We need to freeze and cut the specimen inside this machine. Okay, used mainly for intraoperative consultation in oncology surgery. Okay, it's a little bit about frozen sections. Actually, frozen sections, the procedures is time consuming and quite costly. It's required experience for both our staff, because it's experienced staff, they can make it the section is better, because when we want to cut section during frozen sections, it's quite difficult. Okay, it's not as easy as the usual cutting of the paraffin sections. Paraffin section, because the paraffin is become hardened, so it's easy to cut. In the frozen sections is quite it's not really hardened, because we only use freeze to fix, and then sometimes they depending on the who did the sections. Okay, sometimes it's quite difficult, and the pathologist also needs to make a quick decision, because we will have the certain periods of time to make the diagnosis. For ours, our TAT for frozen sections is 1 hour. From the time you send the specimens days until the results given to you. And the result must be communicated immediately to the surgeons, and the result of the frozen section influence the further surgical intervention or treatments. And the purpose of frozen sections, so first we need, because to establish presence and nature of a lesion, meaning we want to confirm the nature, is it neoplastic or neoplastic lesions, or neoplastic, is it benign or malignant lesions. The second purpose is to determine adequacy of surgical margin. This is quite common. We want to know the margins is adequate. And the third one, to establish whether the tissue obtains contain diagnosable material. For example, in the brain surgery, okay, they did a frozen section because they wanted to know when they take the sections is a lesional area. Sometimes it's quite difficult to see is it lesional areas or non-lesional areas. Then the pathologist should be briefed on the patient clinical history before the frozen sections. That's why in our hospital we ask you at least make an appointment for frozen section 2 or 3 days before the days. Yes, so we need to know the clinical history, so we need to prepare first, then we can proceed with the frozen sections. Okay, the usage, okay, the principal use is the examination of tissue while surgery is taking place, right? So it's not frozen sections when you take the section and you close the surgery, so it's not frozen section, meaning you still, the surgery is taking place and the specimens sent to us, then you wait for the result to come out. And then in the frozen section can give rapid diagnosis because it's about 1 hour per sections, okay, to identify tissue type, as I mentioned to benign versus malignant, identify metastasis. Sometimes we can send the lymph nodes, so we can say it's metastatic. To assess the margins, okay, sentinel lymph nodes normally used for the breast carcinoma. They send the sentinel lymph nodes because in a certain center, they not normally prostate mastectomy with a axillary clearance. So they did the sentinel lymph node first, and when confirmed the sentinel lymph nodes is positive, they proceed with the axillary clearance. And to detect presence of substance loss in the routine tissue process, for example, glycogen or lipid just now, when we want to see a fat, so we need to use a fresh tissue and then we stain with a special stains. Okay, what are the advantages of the frozen sections? Rapid intraoperative diagnosis, okay, 1 hour per sections. Okay, when we do more sections, it takes a longer time because the process is not really simple, and help surgeons decide on the next step in the surgery, preservations of the antigens and DNA, meaning that frozen sections, after finish frozen sections, all the tissue, so we fix in the formalin and we process as usual through the paraffin section, so that we can also proceed with the other staining, immunohistochemical staining or histochemical staining. What are the disadvantages? The technical quality of the section is lower than routine H&E sections because the preservations of the cells is poor. Sometimes it's quite difficult to see the individual cells because of the many artifacts, the frozen artifacts. I show you the slide after this. The specimen is fresh. So it's higher risk of transmitting disease, because in the usual specimen you fix in the formalin, they have many study prove that with the formalin fixations, okay, most of the viral diseases can be many virus can die in the formalin fixations. Okay, so when we receive a fresh tissue, so they have high risk of transmitting viral diseases. Okay, cutting of unfixed tissue sections require plenty of experience. This is very difficult, so we need experienced staff. Okay, this is how we look on frozen sections. Okay, actually this is frozen sections of brain. Okay, this is residual brain tissue. This is the tumor areas. These are the lesional areas. Okay, when we look, these are low magnifications. Okay, you can see a lot of spaces here. Okay, there's a lot of spaces. Okay, actually, these spaces here is all represent the frozen artifact. Okay, sometimes the spaces is a lot. It can cause trouble or difficulty to us in analyzing this slide. Okay, sometimes we see is it the part of the component of the tumor cells or is this artifact. So sometimes it's quite difficult. And also we can clearly see. Okay, there's another example. Also from the brain. Okay, this is how the pituitary adenoma on the frozen sections. This is how the pituitary adenoma on the paraffin section. So on the paraffin section, we can see clearly the arrangements of the tumor cells. You can arrange in the glandular like this, okay, tubules. And then we can analyze the individual tumor cell, all the nuclear features very clearly, right? However, in the frozen sections here, we can't see any arrangement of the cells. And the nuclear features also we hardly see, okay? Yeah, it is quite difficult. That's why in the frozen sections, we cannot give you the final diagnosis for the case of brain tumor. We only can say it high grade or low grade only, okay? Because it's quite difficult. It's like they have the artifact, this one spaces here, frozen artifact, okay? I think, oh yeah, that's all. Okay, any question you want to ask?
Is there any question from the participants?
Anything you want to ask something about the diagnostic histopathology?
Not yet. Not yet. Maybe we can, if you can, anything, we will get back to you via email or anything.
Okay, can, all right.
Thank you very much for Dr. Lana for the time and the lectures.